Thank you so much, everybody, for joining us this afternoon and for taking the time to engage in this very important discussion. As we all know, the World Health Organization released a revised air quality guidelines after 16 years, and definitely it's a major step in terms of understanding the implications that air quality has on public health and the human anatomy. It's very clear that WHO has taken this step to kind of because there is growing evidence and there is growing body of proof which is showing that air quality has impacts the human body across all organs and is leaving very deep-seated and long-term effects, and those need to be addressed with implementing extremely stringent air quality levels in various countries. And India, of course, with some of the most polluted cities in the world and some of the most polluted regions in the world, definitely it puts a lot of impetus on us to see how we can put this front and center of our entire air pollution efforts and the National Clean Air Program and all the work that's happening around it. We have an extremely stellar panel with us today, and if I may just take the opportunity to just introduce everybody here. We have Dr. Maria Neera joining us from Geneva. She is the Director for Department of Public Health and Environment at WHO. She needs no introductions, but thank you so much, ma'am, for taking the time to join us this afternoon. We have Dr. Beena Sahni. Dr. Sahni is the Additional Deputy Director General at...
Sir, good
afternoon. Beena ma'am is the Additional Deputy Director General of Environmental Health at the Ministry of Health and Family Welfare. Thank you so much, ma'am, for taking the time to join us. Your participation really is important in driving this debate further. We have Professor Kalpana Balakrishnan joining us. Dr. Balakrishnan is the director and the WHO Collaborating Center of Occupational and Environmental Health, also the ICMR Center for Air Quality, Climate and Health. She's a Dean of Research at Sri Ramachandra Institute. Thank you, ma'am, for joining us this afternoon. We have Dr. R.S. Dhaliwal. He hasn't joined yet and he might not be able to, but he said that he'll try and attend for a little while if possible. He's the head for the Division of Non-Communicable Diseases at the Indian Council for Medical Research. We have Dr. Sudhir Chintalalpati. He is the Joint Director at the Ministry of Environment, Forests and Climate Change and is looking after the Air Pollution Division and the very important work that MOEF is guiding on air quality management in India. We have Dr. Arun Sharma. He's the Director for National Institute of Implementation Research for Non-Communicable Diseases in Jodhpur. Thank you so much, Dr. Sharma, for joining us. And we have Dr. Shagnik Dey. He's the Professor at the Center for Atmospheric Sciences at IIT Delhi and also the Coordinator for Center for Excellence for Research on Clean Air. Thank you so much, Dr. Dey, for joining us this afternoon. And absolutely not last but the least, we have Mr. Manjeet Saluja, who is also representing us from WHO India office. He's the National Professional Officer at Environment and Public Health. Thank you, Manjeet, for joining us. I will hand it over to Bhargav here. Dr. Bhargav Krishna is he's moderating this session today, and Bhargav, again, to all of you who are here, needs no introduction. Bhargav is a fellow at the Center for Policy Research and recently completed his PhD from Harvard. He was prior to this he was with the Public Health Foundation of India. Bhargav, over to you. Thank you so much.
Thank you, Gunjan. So without further ado, I think we will jump straight into our proceedings today with the keynote address from Dr. Neera.
Thank you very much, and good morning from Geneva. Good afternoon to you. It's such a pleasure to share this morning, to have the opportunity to discuss with all of you. As you say, India is certainly a country, almost a continent that is of extreme importance for us. So we are very pleased to have this opportunity to discuss, to exchange with such an incredible panel of people with, very huge engagement and commitment in all of these topics, and an incredible expertise. For this reason, I will not go too much into detail into the presentation of the global air quality guidelines. I'm sure by now you know that very well. Maybe just some key messages and why we did this and why this is so important. And of course, this is the first reason. I mean, the still horrible figure of the 7 million premature deaths occurring every year due to exposure to air pollution. And this is a totally unacceptable number that is creating probably one of the biggest public health challenges we are confronting. Let me just tell you that yesterday, and I hope you saw it today on some newspapers, yesterday WHO was presenting what we call the health argument for climate action, urging leaders going to the COP26 to take ambitious decisions at the climate change summit, recognizing that health will be the one most affected if they don't take the right decisions, or the one that will benefit the most if the Paris Treaty is implemented. If the climate change agreements are implemented, the huge benefits, the health gains can be enormous. And one of the most important health gains will come exactly from this, from the fact that if you tackle the causes of climate change, one of the benefits, the immediate benefits, will be the reduction of air pollution. And therefore, this will be helping us on reducing this silent killer and this air pollution that is killing so many people around the world. Next one, please. Essentially, what is new on it? Next one, please. Next one. Essentially, next one, voila, this is the key messages that we have updated these guidelines, and as mentioned, since the last 15 years, the scientific evidence have been accumulating, and the evidence is telling us now that we need to lower the levels of pollutants, the 6 key pollutants that WHO has been proposing. And we need to be more ambitious. If we really want to protect public health, those levels need to be lower. And again, I know that this will represent a challenge for some countries, but still, this is where we need to go if we want to protect people's health. And what we know, and this is the incredible news, is that if the countries globally, if we could reach the recommended levels of PM2.5 globally, the reduction in the number of deaths could be around 80% of the current 7 million. So I think we have an incredible mission and commitment here that we all need to align to make sure that we will go for that. Next one, please. Well, those are the levels that we are recommending now and compare with the previous one. As you can see, they are very ambitious, particularly for PM2.5 and for well, almost all of them except for SO2. And that will represent now, we hope, a discussion at national level for each country, each region to see how can we move from it and what it will represent. Next one, please. I'm very conscious of the time, so I don't want to, in addition to the levels proposed in the new air quality guidelines, as you know, we provide various good practice statements for sunny dust storms, black and carbon, and ultrafine particles. So that there are very good practices statements that can help countries to get into this on the most appropriate way. Next one, please. This is where you can compare the recommended levels and compare with the previous one and the average time, and you will see that essentially is well, we are looking at the long-term and short-term exposure, but what we are keeping in mind is the critical health outcomes, and if we want to protect health, as I say, we have to be very restrictive. So we provide those air quality guidelines level, the interim targets, and the good practice statements. I think this will provide a very solid way for countries to move on and to challenge themselves and put in ambitious targets in place. Next one, please. They are so important for health because, again, I mean, the argument of the 7 million deaths, the thing that air pollution is very much at the heart of the NCDs. cardiovascular and respiratory diseases, lower respiratory tract infections, preterm birth, and other causes of death in children and infants. And not only that, I mean, what is costing to our society in terms of healthy lives, years lost every year. So that represents an incredible cost for our society, in addition to the economic cost as well. Next one, and I think I will leave it here. I'm sure that we will have opportunities to, at the discussion, at the debate, to go through the most adequate and appropriate focus questions for here. The number of deaths we can reduce is 80%. And I think this is what we need to keep in mind. This is the little circle that I wake up with every morning, saying, this is the opportunity, what can we do to reach that target? And in 83% of premature deaths will have been avoided in the South Asian region, which is more than 1 million. So I think this gives us an additional reason why we need to, as the health sector, in the broad sense of the word, move this agenda and make sure that now at the COP26, very tough decisions are taken, very ambitious one, and the countries are committed. Next one, and it will be my last one. How can we use? I'm sure that we can discuss at later on at the panel, but nobody can say that they didn't know, that they didn't have the scientific evidence, or they didn't know the recommended interventions and tools to put this in place. I think will require a lot of political courage, and it will require demand by the society. It will require a great commitment to a transformation of our society in the quick energy transition that we all need in order to protect our health. I will stop here, and happy to participate at the panel discussion with more focused questions. Thank you.
Thank you so much, Dr. Neera, for your eloquent presentation, and very rapid, I might add. Thank you so much for covering so much ground so quickly. I'll move on at this point to Dr. Beena Sahni, who will be giving us the perspective of the Ministry of Health and Family Welfare on the new WHO air quality guidelines. Dr. Sahni, I think you're on mute.
Yeah. Can you know? Hello?
Yes, ma'am, we can hear you.
Okay. So I'll be talking on very elementary things like WHO guidelines, WHO definition. Please, next slide, please. Next slide, please. WHO definition of air pollution, types of air pollutants and their health effect, sources of air pollutants, WHO Global Air Quality Guidelines, new WHO Global Air Quality Guidelines, need for new air quality guidelines for protecting health, way forward for India, and air pollution and COVID-19. Next, please. Next, please. WHO definition of air pollution is: air pollution is the contamination of air we breathe indoors and outdoors by any chemical, physical, or biological agent that is potentially threatening to human health and ecosystem. Types of air pollutants and their health effects are: particulate matter, they penetrate deep into lungs and cause lung diseases, and they can be carcinogenic. Then chemical pollutants, they are ozones, they complicate the lung disease, and oxides of nitrogen, they are immunotoxic, and they are potent vasodilators, and they can lead to pulmonary artery hypertension. Then SO2, it can exacerbate the existing respiratory symptoms. And then carbon monoxide. Carbon monoxide binds with the hemoglobin to form carboxyhemoglobin, which causes impaired oxygen transport to different organs. Then, next please. Then there are biological pollutants like bacteria, streptococcus, tuberculosis, pneumococcus, viruses like influenza, mumps, varicella, and corona, of course. Fungus like aspergillus, mucormycosis, pollens, and other allergens. Pollens and other allergens can cause bronchial asthma and eosinophilia. Fungus, everybody must have heard about the mucormycosis. Viruses and all these are airborne infections and they can be very harmful. Then, next, please. Next slide, please. Gunjan, can you hear me, Gunjan?
Ma'am, I'm changing. Can you not see the change slides?
Yes, now I can see.
Okay.
WHO Global Air Quality Guidelines. The purpose is to identify level of air quality necessary to protect public health worldwide and prevent or mitigate climate change. Since the whole world has become a global village, even the pollution in one part of the world affects the other, and the worldwide climate change is occurring. So WHO had to intervene, and they have got 6 classical measurable pollutants, that is PM, particulate matter 2.5 to 10, ozone, oxides of nitrogen, sulfur dioxide, and carbon monoxide. This has already been covered by Dr. Maria. This is new air quality guidelines. And India has not even achieved the old air quality guidelines, but then there is need for air quality guidelines have been revised because they use new methods for evidence for guideline development, reinforce evidence on health effects, provide higher certainty in evidence of health effects occurring at lower levels than previously understood. They offer additional air quality guideline level, such as for peak season ozone and 24 hours nitrogen dioxide and carbon monoxide, as well as some new interim targets. They offer new good practice statements on the management of certain types of particulate matter. For example, black carbon, elemental carbon, ultrafine particles, and particles originating from sand and dust storm. Way forward for India. We have to revisit national ambience and air quality standards to WHO level and implement them without exception. We have no way out. Then we have a national clean air program which targets at zero emission transport, that is electrical vehicles, and use of solar energy. Better monitoring, that is to increase continuous ambient air quality monitoring system. These are the which can measure the air quality correctly. And we have air quality networking for some states like Gujarat, Maharashtra, and Telangana. And we have to put it, center and states have to unite to get this thing network in the whole of India, whole of the country, so that we can manage. Then air pollution and COVID-19. Since poor air quality is important risk factor for developing complications of COVID-19 like respiratory and cardiovascular disease, acute and chronic obstructive pulmonary disease, or myocardial infarction or stroke. People with underlying medical conditions are likely to be at a greater risk of developing severe disease from COVID-19. But during the global COVID-19 pandemic, however, it has been noticed that a short-term reduction of air pollution was there across cities in India. This reduction was more prominent in cases of nitrogen dioxide, a pollutant very much related to traffic, which was dramatically curtailed by lockdown measures. And COVID-19 has been a tragedy, but at the same time, the response measures have shown how policies related to transport and way public work, study, and consume can contribute to a better air quality. Thank you very much.
Thank you so much, Dr. Sani. I'll move on now to Dr. Kalpana Balakrishnan. Ma'am, the recent revisions of the WHO air quality guidelines have, the WHO and experts who have contributed to the revision of the guidelines have spent a significant amount of time conducting a systematic review of the global evidence around the effects of air quality on health, evidence that has been generated in the 15 years since the previous iteration of the guidelines have come through. We often talk a lot about the need for localized evidence as well. In fact, that's something the government in India keeps harping on about whenever we talk about the impact of air quality on health. As somebody who's led a lot of this work personally and with other collaborators in the country, could you speak to us about the sort of leaps that have been made in local evidence generation on air quality and health over the last 15 years or so?
Yeah, well, thank you, Bhargav, and it's great to see all the distinguished members of the panel today. And as someone who's been part of some of these systematic reviews while we were developing the guidelines, it's one important thing to recognize is that while we still have a lot of evidence that is accumulating from India, we have still not been able to sort of really get the evidence base to a point where a critical mass from India gets included in the global pool of epidemiological studies that were considered as part of the studies included for the meta-analysis for both the long-term and the short-term effects. We recognize that the long-term effects have always been a challenge. The cohorts have been relatively far and few in between in India. But even the short-term effect studies, have not been of quantity sufficient enough that we can sort of take it sort of, often the question I'm asked is, how many studies in India got included in the systematic review? The sad truth is that we still don't have studies that are represented in the meta-analysis. But nevertheless, the point that you raise is a very important one, because I think the kind of evidence that WHO has had to use in coming up with these guidelines is based on evidence that is consistently available across all regions of the world and meeting certain, data quality criteria. Of course, it'd be one thing for us to sort of meet the same criteria, but nevertheless, the lack of India-specific studies in that global pool by no means, should be confused with the lack of evidence from India studies per se. Indian studies have looked at outcomes that are not necessarily the same kind of classification of outcomes. Long-term cardiorespiratory mortality has been a very difficult thing to pin down, but that has not stopped us from looking at markers of cardiovascular mortality, other indicators of cardiorespiratory morbidity, other indicators of health impacts outside of cardiorespiratory morbidity and mortality that would provide the same level of persuasive evidence. Just because it does not get included in a specific meta-analysis, the guideline values are very, very difficult to formulate in the absence of consistency across multiple WHO regions. And nobody knows this better than Dr. Nera when we have to sort of deal with so many regions. All regions cannot generate ditto type of evidence. But what we need is evidence that bear consistency with the observed, extent of associations. In that sense, India has made huge strides in generating quantitative exposure response relationships for several health endpoints. And of particular interest, cardiorespiratory morbidity has been reported for a long time now. But what is now important are two classes of evidence. One is on adverse pregnancy outcomes, including low birth weight, in which several now publications are out, looking at both registry-based data as well as cohort-based data on looking at the association independently between household and ambient air pollution and birth weight. And if you look at the birth weight meta-analysis estimate, it is bang on to the estimates that have been observed in cohort studies in India. The birth weight exposure response is not part of the guideline setting value for the meta-analysis, but it is supportive evidence for sort of really looking at, what type of guideline value should you be looking at for vulnerable populations. It's very recently, birth weight has now been included as a category of outcomes for the burden of disease estimate, for example. The second category of outcomes that is of great interest is work led by Dr. Prabhakaran and co. As an indicator of cardiovascular mortality is the exposure response association between PM2.5 and blood pressure, which is, and the exposure response relationships are again bang on, right? Very much consistent with the observed relative risks elsewhere in the world. We can now say that about continuous exposure response functions for lung function, continuous exposure response relationships, several biomarkers. So all in all, I would say that the ongoing cohort studies in India have provided evidence that is very, very consistent in terms of the association, the strength of association. And most importantly, they provide supportive evidence for the sticking on to the interim target guideline value, the first interim target guideline value of 35 micrograms, but we are really looking at, that is still, you are going to get benefits even if we get to 35 micrograms, which is very close to the national standards of 40 micrograms per meter cube. So in that exposure range, the observed exposure response relationships are providing consistent, supportive evidence from studies across India.
Thank you so much, ma'am. We'll return to some of these questions as we move on. I'll move on now to Dr. Sudhir Chintalalpati. Dr. Chintalalpati, as the representative of the Ministry of Environment and Forests, we've learned that recently the government is committed to a revision of the National Ambient Air Quality Standards. In fact, the announcement came just a few weeks before the release of the new WHO air quality guidelines. The NAQs themselves have not been revised since 2009. And now, given the recent revisions to the WHO air quality guidelines, they're even further behind from meeting interim targets set by the AQGs. So, as a sort of observer who was engaged in the development of these specific policies around air quality mitigation as well as measurement and monitoring, what lessons do you think the release of the WHO air quality guidelines give us within the policy making space as we embark on this approach or this effort to revise the National Ambient Air Quality Standards?
Thank you, Bhargav, for giving me this one. I'll just mention to you that our ministry has launched National Clean Air Program. I hope I'm audible.
Yes, sir. You can hear you clearly.
Yeah. So I just want to mention that Ministry of Environment in 2019 has launched the National Clean Air Program with the specific objective of reducing 25 to 30% of the air quality in the identified cities. Like we have identified around 132 non-attainment cities, those cities which are consequently for consecutively for 5 years, which are not meeting with the national ambient air quality standards. So even during that launch time itself, we have identified that there is a great need in order to review or revisit the national ambient air quality standards. So that is already mentioned in our National Clean Air Program document itself. So the provision is there for revisiting the national ambient air quality standards. Further, coming to the last year, the global pandemic year, and because of the COVID-induced lockdowns, we have got a virgin data across the country, how, what do you call that, without human interference, what will be the quality of air, what is the actual achievable standards in case if all the anthropogenic activities are stopped. So we have got the data also. And now the CPCB, our Central Pollution Control Board, so they're also actually working on this, revisiting the national ambient air quality standards. Because as we know that India is a subcontinent, and the temperature varies, the topography varies. So there is a lot of debate which is going on, that whether there should be a single standard or we have to revisit the standards, and what should be this one. So already the CPCB is working on that in that area. Madam is also mentioned that there are no consistent studies which show in Indian based studies which actually are not performed. So the CPCB is working with NERI for revisiting the standards, and I hope soon, as CPCB has announced, I think they will be coming with the new standards. So considering WHO guidelines in focus, so the new standards are yet to be prepared. So apart from that, also the ministry, they are taking several steps in order to bringing the National Clean Air Program into picture. And we all know that now we have launched from BS4 to BS6, we have now leapfrog. So actually there are several steps that are being taken for improving the air quality, like the shifting to the greener fuels. As we all know that we are actually even going for the electric vehicles and all. So all these steps what the government is taking slowly, it is actually having some impact on the air quality. Even if we see the air quality in the Delhi from 2016 onwards, there is a lot of improvement. We can see that in 2016, we have around 108 good days. That is only as per the air quality index. If we classify, the number of good to moderate days is 108. But in 2019, not considering the COVID year, in 2019 it happened to 182. That means almost half of the year we are having the good quality of air. So the ministry is working, the several steps are being taken, and apart from that, considering the WHO guidelines, and the ministry is also actually in the plan of revising the national ambient air quality standards. Yeah.
Thank you, sir. Thank you so much. Dr. Arun Sharma, the WHO's revisions of the air quality guidelines have sort of sent a message to health professionals as well, in addition to all of the other stakeholders who are deeply involved in these dialogues. We've seen in India there has been a sort of burgeoning movement of physicians and other health practitioners engaging in discourse around air pollution. But as a physician and who's working on broader issues of chronic diseases, what is the message that you take away from the revision of these guidelines, and what it means for the broader practice of medicine as well as for the healthcare system itself?
Yeah, thank you, Bhargav, for posing that all-important question from the health perspective. We are already familiar with the fact that the major brunt of air pollution is on non-communicable diseases. And starting from the respiratory system, as Dr. Balakrishnan was mentioning, that even on intrauterine growth retardation and problems with the delivery of newborns with lower birth weight and other complications are being considered as evidence of air pollution related issues. And not to forget the evidence that's generating in changes in cognitive human behavior and also in endocrinal diseases like diabetes mellitus. So you can see that the entire spectrum of non-communicable diseases is affected by the air quality. So the importance of non-communicable disease in the causation of non-communicable disease of air quality cannot be overestimated. We are definitely into it. And this new air quality guideline also emphasizes the fact that by lowering the standards, we are in a way scientifically accepting that probably no amount of exposure to the particulate matter can be considered as safe, because bringing it down to as low as 5 microgram for PM 2.5 is a warning sign that even with such minimal concentration, it's going to affect our health adversely. So the take-home message, according to me, is that on the basis of these am I audible?
Yes, sir. We can hear you clearly.
Yes, sir, we can hear you. Can you hear us?
Can you hear us? Have we lost him?
I think he's frozen.
Okay.
Looks like it.
I think Dr. Sharma's connection may be a little weak. So why don't we move on, and we'll get back to Dr. Sharma shortly. Dr. Sagnik, Sagnik, we've spoken a lot about how essentially, as a result of these guidelines, large parts of India, over 90% of India, most of the world essentially will not be able to meet, will not be considered as having clean air or air satisfactory to protect public health. But the challenge that we also have in India is essentially that we have an extensive, now growing monitoring network in urban centers, but large parts of the country remain unmonitored. In the absence of this kind of ground monitoring data, how do we supplement that lack of data with tools that you have been deploying using, say, satellite data or hybrid models to try and inform guidance and policy making in these sort of rural as well as peri-urban areas that are as badly affected, if not more, than most urban centers?
Thank you, Bhargav, for asking this question to me. So couple of points on this. Hope I am audible.
Yes, we can hear you.
Okay, yeah, perfect. Yeah, so government is already looking into alternate ways to measure air pollution. So in fact, we are doing a project for the Central Pollution Control Board where we are mapping PM 2.5 using satellite data and then locally calibrated. So we have developed this database. And in fact, once we have this kind of data set, Dr. Chintalapati mentioned about the baseline concentrations, what we found during the lockdown. And again, those numbers are only from the urban areas where actually the ground-based monitors are located. So what we learned from this nationwide data, which is basically the satellite data calibrated against ground-based measurement, is that although air quality significantly improved during the lockdown, but we could not sustain it throughout the entire 4 phases of lockdown nationally. In fact, when we looked into the data, particularly over the rural areas, we find that there was not much significant improvement in the rural areas. And clearly the reason is that during lockdown, 2 sources were completely, was not actually, vanished. So one is the domestic emissions and burning, and the second is the open biomass burning. And mainly because of these 2 large regional sources, at a regional scale, air quality could not improve. And in fact, there are many studies clearly pointing out that these are very important sources. So it clearly means that we need to really keep an eye not just at the urban centers, but also at the periphery and beyond. And that's why I think it's very important. And obviously at the same time, one can argue that, obviously resource-wise, India is not in a position to, go and put out as many as CAQMS as we wish. And that's why I think this kind of hybrid approach is extremely important, where strategically we can, position the reference grid monitors so that satellite data can be calibrated against them, and as well as we can develop hyperlocal information using portable low-cost sensors going forward in time. Because obviously, few reference grid monitors can never actually provide local scale information. And those are extremely important to really understand the efficacy of any intervention measures For example, in my neighborhood, if there are certain sources, it cannot be captured if the reference grid monitor is a few kilometers away. So to really go in that direction, in my opinion, relying on technologies is that with this kind of system, we can then sort of look into the effectiveness. And there, I think, again, the key issue comes back when we talk about implementation, because we really do not have any prioritized list of actions. All we have is a long wish list that we have to do X, Y, Z. So 3 points are extremely important if you try to prioritize clean air action plan. First, obviously, we need to target the sectors reducing emissions from which actually are expected to provide larger health benefit. Second is that we need to look for cost-effective measures. And the third is that there is an opportunity also to tackle climate change. So we must prioritize sectors that co-emit air pollutants and greenhouse gases. So at least, these 3 important points, if we keep in mind and try to prioritize then the Clean Air Action Plan, I think not only regional scale, we would achieve relatively cleaner air, but also simultaneously address the climate change issue to some extent.
Thank you. Thank you so much. I think you touched on a similar point that Dr. Neera also made on the climate co-benefit associated with action on air pollution emissions as well. Moving on to Mr. Manjeet Saluja. Manjeet, could you inform us on how the WHO is engaging on raising awareness as well as working with the government here in India on mainstreaming the air quality guidelines, please?
Right. Thank you, Bhargav. Thank you for this question. And I think we have already heard from all the distinguished panelists till now on kind of the various measures. So I think this is no new information that air pollution is certainly one of the biggest kind of environmental threats to the human health alongside climate change. And we already have sufficient national and international evidence. We have already heard Dr. Kalpana talking about it. We are aware of the ICMR's landmark report of the Health of the Nations report of 2017, which identified air pollution as kind of one of the second leading risk factors. So there is kind of national evidence, and there is a recognition of that. And it's not that it's only evidence. India has kind of taken actions, and we have heard Dr. Sudhir kind of talking about the efforts of Ministry of Environment, Forest and Climate Change for implementing and kind of initiating this National Clean Air Program, which has a goal of achieving 20 to 30% reduction in the particulate matter. And it's so one side is certainly the Environment Ministry, but then we also kind of see certain other kind of sectors also kind of contributing to it. We know about how India's ambition has been raised on the country's renewable energy target, the international, India being one of the founding members of the International Solar Alliance. Also, in terms of the household air pollution, we already have a large kind of program on clean cooking gas, which kind of has given 80 million poor families which have kind of replaced polluting biomass fuels. And also, again, when we look also at the transport sector, New Delhi has one of the most comprehensive kind of EV policies, which came out in 2020 to reduce kind of air pollution. So I think that's where we see a lot of kind of multi-sectoral actions kind of coming in. And when we talk about I think the Health Ministry, and there we see that it's one of the pioneering efforts which was taken up by the Ministry of Health and Family Welfare, where it initiated a national program on climate change and human health, which is kind of which is being implemented by NCDC, the National Center for Disease Control, and kind of WHO India is closely supporting this particular program. And some of the notable areas of cooperation and kind of the main key highlights of this the national program on climate change and human health, which I would certainly kind of like to mention. So what the whole program is talking about is kind of supporting and the whole purpose of the WHO's support to this program also is to kind of support the government in developing solutions and building the health sector capacity to kind of take a lead, so that this is a health issue, as I think Dr. Maria has many a times talked about, as climate change and kind of it's certainly a health issue. So it has to be looked from that perspective. Then developing kind of advisories to communicate that health impacts of air pollution and kind of strengthening on the data and the surveillance aspects. How kind of this information on, it's not only the AQI, which is a number, but then how it does translates to the health effects and how it is communicated to the people. Then we also kind of trying to interlink with climate change. And again, as we have heard Dr. Maria and Dr. Sagnik kind of talk about climate change, that mitigating climate change would certainly kind of help mitigate air pollution, and also vice versa as well. So we are trying to develop frameworks for example, on climate resilient hospital infrastructure, which we kind of piloted in Madhya Pradesh, so that even the health sector also kind of leads from the front and reduces its own kind of footprint on this issue. Then we are also kind of providing technical guidance on the health vulnerability and adaptation assessments. We did some pilots in various states of India on various disease outcomes, for example, Rajasthan and kind of a few other states. We are also trying to develop the capacities and kind of through that also certain training modules for vulnerable population. For example, just on 7th of September for the International Day of Clean Air, I think NPCCH along with WHO support, we released a set of 4 modules to kind of help sensitize and protect vulnerable populations like municipal workers, traffic policemen, women and children from air pollution. And this particular work was undertaken along with support of PHFI. So what I kind of have to put out here is certainly there needs to be a multi-sectoral approach is kind of critical, since the sources of pollution kind of span across different sectors, which is kind of we are already aware of it, agriculture, transport, and there are actions which are already happening. Yes, the government at all levels needs to kind of come together, and we need to work towards it, so that the slide which I think Dr. Maria showed in terms of the interim targets, so that India can kind of work on that, and we are able to achieve finally with all these actions put together, I think India moved towards achieving the air quality guidelines set up by despite all the kind of challenges of background dust and all, but then we are able to kind of achieve those targets in future. And certainly WHO is kind of from the country office, we are committed to supporting the government in this fight to address the health impacts of climate change and air pollution. So I'll just stop here and maybe come back later. Thank you, Bhargav, over from my side.
Thank you so much. We'll move on to some questions first from me and then from the audience. I would like to start first with Dr. Maria Neira. Dr. Neira, your presentation and the revision of these guidelines themselves have left a sort of deep mark on discourse around air quality and health, in the sense that essentially the vast majority of the world is going to be struggling to meet these new air quality guidelines. Most parts of the world will not be able to meet the 5 microgram annual exposure for PM 2.5 levels. At least in India, almost every part of the country is unable to meet these standards. You also were explicit in linking the climate co-benefit of addressing air pollution, and you've mentioned the COP26 side event as well that's going to be happening right now. In all of these linkages, is there a specific message that the health sector is sending to other sectors around the need for a different development pathway that takes into account economics, energy, and health?
Yeah, thank you. Thank you very much for the question. And thanks to the panelists, because it was really very, very interesting and of course, very much to the target and very much needed this dialogue. Of course, it will be very difficult to reach those targets, no doubt. But some similar comments were made 20 years ago when the first guidelines were presented, and people were saying this will be impossible. And today, fortunately, we have in the European Union, for instance, and North America and other countries where we are almost there. Of course, this little piece that they are missing is it will be even more difficult to achieve. What is the role of the health sector? Fundamental. Yesterday was this letter co-signed by 45 million members of the health community, and I hope you all sign, and if not, you are still on time, asking leaders at the COP26 to put health at the center of the decisions they will be taking at the COP26. Most of the decisions we will need to take for tackling the causes of climate change will benefit air pollution. And those decisions are very much government decisions in terms of the energy transition that is needed, the moving quickly or as ambitiously and as quicker as possible to these renewable sources, clean sources of energy. This is one thing. Very much will be about the transport policies that, again, and mobility related policies that we need to change completely. The food production, the food systems on a more sustainable way. But it will come as well from the demand from the population and the demand from our citizens. And in that sense, I think the awareness is growing around the world around the fact that if you are exposed to air pollution, your health will be at risk. And the voices of the health professionals are now very, very strong and very loud. And we think that if pediatricians, if family doctors, if respiratory doctors, if the health community at large will start to say, hey, this is a health problem and not just an environmental issue and not just a planetary issue and not just an issue for the next generation, I think we will have some chances. I will go for the legislation as well. I will not forget the legislation and the importance that legislation can have in this issue, but our individual measures, our behavior change will be important, but some critical decisions on some transformations that are needed needs to come from governments on a very ambitious way, I hope.
Thank you so much, Dr. Neera. To Dr. Chintalalpati and Dr. Sawhney, a question more on the sort of multi-sectorality of the issue. We heard from multiple speakers that action is needed across different sectors, and we need sort of collaborative work that is carried out across all of these different sectors. So, Dr. Chintalalpati, if I come to you first, the NCAP as well as a host of other environmental and air quality related policies are driven by the MOEF, but there seems to be little means of direct engagement with stakeholders, say from the health sector, either through the Ministry of Health itself or through external experts. I know there are some experts who are invited from time to time on various bodies that are debating air quality policy, but it seems like there's no systematic means. Is there a way through which this kind of multi-sectorality can be fostered and we are able to drive the health messaging as much as the broader sort of technological as well as financial feasibility related messaging on air quality in India?
Yeah, thank you very much, Bhargav. The first thing is that the NCAP basically is like a convergence program where we are trying to address bring the intersectoral coordination. The multi-sectoral sources of pollution are being addressed here. So we have several committees and we have several panels where we are seeking the interministerial coordination, and also we are trying to bring the several stakeholders on a single platform, and we are trying to address the air pollution in a very, very convergent way. Like, for example, if you see the Ministry of Housing and Urban Affairs, they are actually being engaged in the Swachh Bharat Mission 2.2, wherein one of the major objective is the management of the solid waste and the legacy waste and several other things, which has a direct impact on air quality. Same way, if you see the Ministry of Power, they are actually shifting this thermal power plants and all. They are going for an installing of this flue gas desulfurizer FGD, which in turn reduces the air quality, which in turn reduces the emissions of SOx and NOx into the air, which has a direct impact on air quality. So apart from that, we are also in touch with the Ministry of Agriculture, wherein they are working on the in situ and ex situ arrangements for taking care of the stubble burning and all these things. So in order to reduce the stubble burning issues. So, and also like Ministry of Power is also actively involved in to make these biopellets out of the stubble and then use it in a waste to energy. This one. So MNRE is also involved, and it is also like I think Dr. Manjit has also mentioned that India has taken a lead to become for solar lead. So it's they are trying to shift towards a very cleaner fuel. So we are trying to shift towards the solar power and nuclear, so that the overall emissions of burning of the fossil fuels is reduced. So the NCAP mission, the NCAP, basically the objective is to bring all these several ministries on a single platform and work together for achieving the target. And as you already know, the several ministries are already working, like MOPNG and Prime Minister Ujjwala Yojana. So wherein the indoor air quality is being improved, the LPG has been supplied for them, that cylinders are given for them in the free as a subsidy or in free, so that the people can shift towards cleaner fuels rather than going for this one. So there are several, if you see overall in the ministry, government, this one, the several schemes have been taking care, which has a direct or indirect impact on air quality. So the NCAP is actually systematically bringing all these people on a single platform, and we have several committees like steering committee and apex committee under the chairmanship of our honorable minister and secretary, wherein we have inter-ministerial coordinations at the state and central level in order to work in a single platform. And in fact, we also requested all the state pollution, all the states also to form the air quality monitoring cells, which actually comprises of people from the several sectors, like somebody from the housing and urban development, somebody from Ministry of Power, Agriculture. So they all come together and form an air quality monitoring cell in order to work for the air quality, for the betterment of the air quality. Yeah, I hope it addresses.
Thank you, sir. I think the only ministry that I did not hear in that list was the Ministry of Health, which hopefully will soon change.
No, Ministry of Health is also there. Ministry of Health is also, we are working with them. Yeah.
Okay, thank you so much. I know you have to leave now, sir, so thank you so much for joining us. Dr. Beena Sahni, I'll pitch the same kind of question to you, in the sense that the Ministry of Health was sort of taking the lead several years ago by engaging on the issue of air quality by constituting a steering committee on air pollution and health, of which Dr. Balakrishnan was a member as well. And as part of this, the Ministry of Health put upon itself the responsibility of trying to engage across different sectors to influence policy in a way. Is the revision of these guidelines and the message being sent out by the revised guidelines a renewed call for the Ministry of Health to engage more deeply across other sectors?
Actually, ultimately, Health Ministry is the one which is getting the health effects of the whole air pollution. Basically, the health effects are the ones by which we are bothered about air pollution. It is, the pollutants are carcinogenic, they affect the respiratory system, they affect the COVID-19 has also happened. So, and it is not affecting only one country or one segment or one city. The effect is all over the world. So, and the climate change is occurring all over the world. It is now, everything has to be thought for the global system, not as for one country, like Dr. Maria said. So, like we are developing countries. Earlier, we were facing the brunt of the pollution, and we were having maximum cases of respiratory diseases, bronchial asthma, all these things. But slowly, because the atmosphere or the thing is shared for everyone. So slowly the climate change is occurring even in European countries, America, everywhere. So the ultimate effect is of pollution is on the world as a whole. So everyone has to work towards it so that whole mankind is safe.
Thank you, ma'am. A question for Dr. Balakrishnan, ma'am. We've discussed a lot about ambient air quality and the new standards and the importance of different sectoral emissions. Both Manjeet as well as Sagnik mentioned the important contribution of household air pollution in this context. Household air pollution exposures, you've been involved with the revision of those household air quality guidelines as well in the past. Are orders of magnitude higher than ambient exposures in most parts of the country. Household cookstove smoke also contributes anywhere between 15 and 35% to ambient air pollution in different parts of the country as well. Dr. Chintalapati also mentioned the importance of the PMUY as an important initiative to address air quality, but it seems like there is there's a sense of stasis that has been achieved in that program now. Where do you see efforts on addressing household air pollution exposures going forward as an important means of achieving broader ambient air quality and climate goals as well?
I think, we have now at least a dozen studies that have provided unequivocal proof that, using the household emission sector, as the first target for reduction of emissions would be the lowest hanging fruit. It is a sector that is already identified under the National Clean Air Program. It provides dual benefits of reductions in indoor exposures and ambient exposures. It is very much within the framing of the National Ambient Air Quality regulatory purview. As you can recognize, while the National Ambient Air Quality, ambient air quality monitoring standards do not sort of, exclude rural areas. There is very little, compliance, machinery out there, mainly because of logistic challenges in terms of the infrastructure required for monitoring. But more importantly, just because we don't have rural ambient air quality monitoring stations doesn't mean that 80% of our population is actually protected. We talk about non-compliant cities, but where are the non-compliant rural ambient districts? Where are the rural villages? Can we really book village municipalities for non-compliance? You can't, or are we going to book households for this? So therefore, really getting the information across to the relevant ministries. Of course, Ministry of Petroleum has spearheaded this effort of providing clean sources of energy for household cooking. Greatly informed by work of doyens like Professor Kirk Smith and many of the Indian colleagues like us who have been working with him. But it was not a health argument that was the primary driver for that program. A health argument was added very much to substantiate an energy and the quality of life improvement initiative of the ministry, because that's the prerogative of that particular ministry, right? So the minute they already introduced it, and we were able to sort of really add the health argument and strengthen it. Now is the time for Health Ministry to really strengthen the hands of Ministry of Petroleum and Natural Gas, saying, look, you just keep doing what you are doing, but do it for more reasons than what you're already doing it for, because it will give you health benefits, it will give you climate benefits, it will give you ambient air quality, monitoring compliance, but emissions benefits, and there are just so many arguments now in favor of the PMUY. And during the COVID pandemic, PMUY has already tested the feasibility of giving up to 6 cylinders of LPG refills free. So they have already established the feasibility in many, many ways. So 6 cylinders will see through more than 80% of our rural population completely for their household cooking energy needs. This almost seems like the biggest opportunity, and in fact, we are colleagues at WHO are working very closely with us to sort of really look at helping us with this messaging. And I would very much implore, Manjeet and Maria to help us in this effort, and the health ministries to increase the pitch. Here is a program that affords the best possible, way forward. And then this would be the biggest natural experiment that one can roll out, right? Entire villages that would go completely, biomass combustion free or solid fuel combustion free. And then you would, really have this, this opportunity to sort of really look at many other pieces of epidemiological evidence that you can gather at a later date. But right now, exposure reductions that are achievable by targeting a sector that is already well tested out is as best as an opportunity you can get to go forward on this.
Thank you, ma'am. Dr. Nehra, you had your hand raised. Do you have an intervention to make here?
Yes, thank you. Thank you for the opportunity. It was just to reinforce what just Dr. Kalpana says. I think this is the health community issue. That's why in WHO we are declaring air pollution as one of the biggest public health problems we are confronting. It's the number one when you look at the first environmental risk factor. But when you are confronted with 7 million premature deaths every year, hundreds of years of quality of life lost, when we are talking about losing working days on a level that is putting at risk the economies, when we are talking about the price that is paid by our hospitals, but our health system, which is an argument that normally is not incorporated, because you know the fact that the investments you need to tackle the causes of air pollution is sometimes used as an obstacle to do more on tackling and promoting air quality, while you are doubling or tripling the cost. So we could, those investments, the health benefits will certainly outweigh on a very important manner the investments you need to do. So all of those arguments, and I think that the health sector has to lead now this movement for air quality, as we did for access to safe water and sanitation in the past. Because it was as we did on healthy food, as we did on avoiding, you know, the exposure to the major risks. And unless we provide this health argument, the level of ambition and the speed will be low. We saw it in many other environmental issues like mercury, exposure to mercury, exposure to asbestos, tobacco is another example. So yes, we need as the health sector to lead this, because this is representing a major burden for a major cost and a major risk for the health of our citizens. Thanks for.
Thank you, Dr. Nira. You've given me my perfect segue to move to Dr. Arun Sharma. Dr. Sharma, just carrying on from the point that Dr. Nira just made, a precursor to most of these shifts in environmental policy has been the role of the health sector, not just in raising awareness, but also advocating for change. Whether it be lead or DDT or mercury or asbestos, all of these environmental toxicants have had significant effects on human health. Physicians have been the ones leading the discourse around these issues from the front. But where do you see the role of physicians in India at this point in time? First, on raising awareness so that people can advocate for change, but and then secondly, as advocates themselves calling for change around policies.
Absolutely, that's a very important point, in the sense that if we try to find out that the general physicians or general healthcare providers, how much awareness they themselves have about the role of air pollution in causation of disease, that will be a big problem, in the sense that if you look at these, most of the non-communicable diseases, most of them are multifactorial in nature. The risk for the disease is not specific to air pollution only. All these diseases have multifactorial origin. So the emphasis, even in medical literature or in medical education, on the role of air pollution in causes of disease is not yet well emphasized. Therefore, if you talk to the physicians who are at the primary healthcare level, whether it is about diabetes or whether it is about COPD or bronchial asthma, recognizing that air pollution is one of the important risk factors in this condition is missing. So I will suggest that in all these scenarios, the first important thing is to make adequate awareness among the healthcare providers, particularly doctors in primary healthcare and secondary healthcare setting, to realize the significance of air pollution in causation of these diseases. Because unless that happens, it's not going to translate into the right communication for the community in general. Now, why I say that? If a patient comes with diabetes mellitus to a patient, have you ever heard a physician telling him that it is air pollution which is causing the disease to you? Or for that matter, even if a COPD patient comes, majority of the physicians will say that it is either because of tobacco smoking, or it is because of the domestic air pollution which is caused by exposure to the biomass fuel. But the general exposure to air pollutants in the ambient air or in the household condition is not being recognized. So the point I'm trying to make here is that the doctors themselves first have to be made aware for the need of emphasizing the role of air pollution in causation of majority of the diseases and the quantum contribution that it makes to it. When we talk about data of 7 million premature deaths or number of DALYs lost, this does not really translate to the communication between an individual doctor and a patient, because these figures don't mean anything in the treatment profile or the management of the patient. So from that, the doctors need to take out the messages which are more relevant to to their patients or to their consumers, if I can use that word, and emphasize upon the need of making the environment clean. So how does it translate into behavior change? That is what ultimately it comes down to. So in behavior change communication, you take some examples. We started using masks not when air pollution was considered as a factor against which the mask should be used. We started using masks when we saw a direct imminent mortality from COVID-19, and mask was seen as a prevention. So the number of people who started using mask, or proportion of people who started using mask, was n times higher than the number of people who thought of using masks when we said that the Delhi has become so polluted in the month of December and January in the year 2017 and 18 that you need to go out wearing a mask. We could not dent that. That means the appropriate behavior towards eliminating the impact of air pollution in the ambient air or in the domestic condition is not yet emphasized enough for people to make that behavioral change. So the grassroots level performance should come from bringing about awareness among doctors and emphasizing the need for bringing changes at individual level, not at a country level or a state level. I'll stop at that at this moment.
Thank you so much, Dr. Sharma. I think this is the sort of last question from me to Dr. Sagnik Dey. In the meantime, if attendees have any questions, please drop them into the chat box or the Q&A section, and we're happy to take them immediately after this question. Sagnik, both yourself and Dr. Chintalal Pati mentioned the NCAP and the various plans under NCAP for non-attainment cities to submit action plans and meet the 20 to 30% reduction targets that have been set. But more and more that we see that this plan seems somewhat incongruous with the broad and nature in which air pollution affects the Indo-Gangetic Plain, but also other parts of the country, where it's not any single urban local body or city which can have significant impact, but rather this needs to be approached from an airshed perspective. Could you speak a little bit to that?
Yeah, I think that's very important point, Bhargav. Yeah, definitely. I mean, without an airshed approach, no city, particularly in the Indo-Gangetic Plain, can achieve this 20 to 30% reduction, which is set as NCAP target. Having said that, the first step would be actually to identify the airsheds. In fact, some work has been done. NIRI has identified. I mean, NIRI is in the process of identifying the airshed for Delhi. And similarly, when we looked into the satellite-based data over last 20 years or so, the entire Indo-Gangetic Plain itself is appearing as one major big airshed, giant airshed. Because what happens is that, geographically, it's kind of confined between Himalayas and the central mountain highlands. So basically what happens is that there is no other way to disperse air pollutants. So what happens, the meteorology kind of oscillates. So air pollution moves from west to east and east to west, depending on the wind direction. So the only way to flush out pollution is through Bay of Bengal. And that is why, at least for Indo-Gangetic Plain, we need to really seriously think about airshed. And it means that all the state also have to come on board. Because currently what is happening, each city has its own plan. Even within a state also, for example, Uttar Pradesh obviously has the highest number of non-attainment cities, right? Within IGP. So, but if you really see, there is no even coordination between the cities. Particularly if we take the example of Kanpur and Lucknow, they are very close to each other. However, there is no interaction even between these two cities. And since Lucknow is downwind of Kanpur most of the time of the year, unless Kanpur really implements the plan. So yeah, I mean, definitely without that kind of regional airshed, we will not really see any improvement.
Thank you so much. I'll move on to questions from the audience now. I'll start with a question here from Vinoj Velu, who says, who is essentially asking whether having a normative goal of improved air quality is great, and we should set very ambitious targets for air quality, but is this kind of very ambitious air quality guideline putting excessive pressure on developing economies like India, where the need for poverty alleviation as well as broader economic growth is as imperative as addressing air quality related issues. So I'll put that to Dr. Neera.
Yeah, I understand very well the debate that is ongoing. Yesterday, we were talking with the Ministry of Ecological Transition in France, and she was telling us that for some people, even at the government level, they still think that this ecological transition is an obstacle to the economic development. And this is wrong. This is completely wrong. Actually, fighting climate change, fighting air pollution, and reducing poverty are exactly the same agenda. It's exactly the same. I mean, by moving into a more sustainable development trends, by accelerating your transition to renewable sources of energy, your economy will benefit enormously. Look at the Nordic countries, look at the Scandinavians. I think they are a very perfect example of that. They are ecologically and environmentally friendly. They are not polluting everything they are touching, and their economics are very good. And I think in many countries in Europe did exactly the same road. You know, I'm coming from a region in Spain, which was one of the most polluted one because we were using coal. And today we are not using coal, and there are only benefits, economic, social, mental health, and of course the cost for the health of the people and for the health system. So I think if on a strategic term, on a wise way of development now, addressing poverty and reducing the causes of pollution and changing all of those unsustainable, unhealthy choices that we are making in terms of access to energy, the way we produce our food, the way we organize our urban settings, that are all contributing to poverty more than fighting to them will be going against poverty alleviation. So my call will be for this wise approach as we propose in the manifesto, you know, for a healthy and green recovery and economic recovery by adjusting those infrastructure failures that we have detected, and that it will require, of course, a government strategic approach, a holistic approach, many sectors involved, private sector involvement, but the results will be very beneficial, and not only for health. There will be beneficial on the creation of green jobs and on the creation of the new and more sustainable ways of economic development. Over.
Thank you so much. A question for Dr. Arun Sharma. This is from Swagata De. Do you feel there is enough capacity amongst healthcare professionals to record clinical symptoms and associate them to air pollution trends? This will help in developing epidemiological models. Can we start somewhere?
I definitely agree that healthcare physicians have this capacity to analyze the signs and symptoms of diseases and integrate with the exposure to the air pollutant and other risk factors. This is quite possible because this does not require any kind of in-depth investigation or very detailed investigation. It is a question of empirically assessing the different type of exposure environment one is living in. For example, if we ask a person that what is your workplace? Are you working in a very polluted atmosphere? Like, are you working in a kitchen, or are you working in a godown where there is a lot of dust is generated, or are you working in an agricultural farm? This empirical question will itself give an answer that what kind of atmosphere the person has been working in, and basically asking about the quality of ventilation that is present in his household in terms of air quality, and the kind of fungus or microbes that are present in his washroom or other places, determining a scenario of what kind of exposure the person is facing due to air pollution. That is very easy to assess. It's a question of just making them aware of the fact that they need to ask this question. That is more important than thinking whether they have the capacity or not. Even a basic medical practitioner can ask these questions and generate this kind of data. Back to you, Bhargav.
Thank you so much, sir. So there are some questions here which are sort of highly specific to Ministry of Environment related policies. Unfortunately, we don't have Dr. Chintalalpathy with us anymore. But if I were to take some of the broader questions, let's start with the issue of affordability of LPG cylinders under the Ujjwala Yojana. Dr. Balakrishnan, we've had sort of significant hikes over the last several months on the cost of LPG cylinders that are unsubsidized, and of course, beyond the sort of first 6 cylinders that are subsidized under the LPG program, essentially now your market rate is becoming unsustainable for families to afford. So how do we address this challenge?
Yeah, see, this is where the Health Ministry's dialogue with the Ministry of Petroleum is really important. If you're looking at purely as a fiscal measure, it is a very difficult proposition. We invest on a lot of things for health, not looking at the fiscal allocation, mainly because these are investments on health. So whether it is vaccines or whether it is other kinds of life-saving drugs, we come up with allocations that are important for health. And therefore, if a lack of LPG is not just viewed as a lack of access to clean energy, but as a major contributor of ill health to rural populations, there would have to be some reallocation of resources. I'm no expert on financial planning for intersectoral cooperation like this, but certainly the messaging has to get across that not just for the short term. I think the question was talking about COVID-related disruptions in livelihoods that is making even more difficult for the rural populations to afford even the subsidized LPG cylinder prices. This is going to be, we are never going to have enough affordability by the rural populations to buy clean energy on a continuous basis. So therefore, this has to be a health-based allocation for clean energy. We have to find development aid. We have to find other kinds of assistance to these poor populations, because these populations have no chance of becoming healthy before they become wealthy. That is a classic public health principle, that you have to really invest on these people. So we have to find resources for these people and sort of use the scientific evidence that we have to make a case for this, and in turn reap benefits of compliance to existing national standards. So this is sort of the win-win that I can think of. If you are expecting that PMUI can do this alone, no, because that's not the priority of PMUI. PMUI is already subsidizing, but it's purely increasing the clean energy access to the best of its possibilities. Or do they have a health target in mind? Do they have to sort of completely replace PMUI provide cylinders to eliminate biomass use? No, that is not a health mandate for them. They have a clean energy mandate to increase the levels of use of clean energy, but that may not fulfill our health requirements for these populations. So if we can marry the existing infrastructure, we have an existing infrastructure, we have a mechanism of subsidization, we have to now identify how to pump in more resources to enable these subsidies to continue at scale and continue for the long term, till such time we are able to find enough affordable energy for everyone.
Thank you, ma'am. Saknik, a question to you in reference to Dr. Chintalalpathy talking about a baseline study that was conducted during COVID-19 to assess PM 2.5 levels from contributors. I think this is the question is of really relevance of this study in informing policy moving forward, beyond the sort of novelty of understanding that eliminating many sources of localized air pollution, including transport, for instance, will improve air quality? Is there something that we can learn from such an exercise? And second, on the importance of transboundary air pollution, which you raised earlier, how many states or how many stakeholders are we really talking about if we're looking to address air quality in this region?
Yeah, so the second question first, Bhargav, that yeah, definitely. I mean, as I mentioned, that Indo-Gangetic Plain is a giant airshed. So it means that people living in the eastern part of this region actually continuously receive pollution from the western part. And then Delhi is not just the kind of boundary. I mean, we often overemphasize on Delhi, particularly because of its political importance, but we never talk about Delhi's air pollution moving to Ghaziabad or Faridabad even. Forget about Uttar Pradesh. So yeah, so in a nutshell, basically all the states in the Indo-Gangetic Plain have to come on board. There is no other alternative. But specifically, the western part, probably you can think of a smaller airshed where Punjab, Haryana, Delhi, and western part of Uttar Pradesh, and then central to eastern part, Bihar, Jharkhand, and West Bengal could be another kind of smaller airshed. But definitely, I mean, that is the most essential. And the first question, yeah, obviously, we have seen that during the COVID, if I understand the question correctly, that yeah, the important lesson is that yes, air pollution can be reduced by reducing emissions. I think that's the most important and simple message from the entire lockdown experience. We cannot clean air, unfortunately, once the air pollution is out there. Whatever we do, try to, I mean, simply those kind of purifiers or all these things, they don't work really. Simple message is that we have to curtail emission at the sources. Thank you.
I think that's a great point to touch on. Also, I think since we're looking at the scale of investment that's being made through NCAP in terms of grants to cities and urban local bodies through the 15th Finance Commission, and compare that to the scale of funding that's provided for standalone projects like smog towers in Delhi, and it's really no comparison at all in the amount of money that is being spent and the kind of impact that, or lack of impact really, that this kind of initiative is going to have. If I were to move to Dr. Beena Sahni, I think Dr. Balakrishnan during this conversation has twice mentioned the importance of the Ministry of Health in driving policy change across sectors, especially as an additional voice or a supplementary voice in the discourse around household air pollution through the Pradhan Mantri Ujjwala Yojana, driving messaging around health. In fact, this is something that was also recorded quite prominently in the recommendations of the Ministry of Health's own steering committee on air pollution in 2016. Is this something that you can speak to? Is this something that the ministry sees as a role it envisions for itself? Because we, as individuals working across different sectors, see that there is Dr. Chintalal Pati, even in his talk earlier, mentioned interactions across so many different ministries, but we really want to see Ministry of Health more engaged. And how do you see that happening? Dr. Sahni?
Can you hear me?
Yes, ma'am, we can hear you now.
So, we also want intersectoral cooperation between the different ministries, because we can only recommend and we can only show the impacts of air pollution on human health. Like there was in rural areas, there was a lot of ladies suffering from asthmatic bronchitis and all respiratory diseases, and it has made a lot of difference after Prime Minister Ujjwala Yojana has given them the smokeless fuel for cooking. So it has made a lot of difference. There is no doubt about it. But we can only recommend how can we provide anything. Like I went to Himachal Pradesh in CRM. CRM is the Common Review Mission for the National Admission. Like at the end of every year, we visit the states to see the impact of our work. So I had gone to Himachal Pradesh, where we were questioning a household that have you been provided LPGs. So they say whatever is provided free of cost, we use that. And after that, we don't have any capacity to buy it. So rest of the time we use fossil fuel only, like then whatever they get and all. So it is not in the hands of health ministry in any way.
Thank you, ma'am. With that, I think we have exhausted all the questions from our attendees. So we'll move to a round of closing comments from our panelists. Actually, one last point for Manjeet. There was a request for data on the hospital that you had shared regarding, I believe it was on the climate resilient hospital infrastructure pilot that you were talking about. If you were able to share that with the GSCC team, it'll be shared with all of the participants who are interested. Thank you so much. We'll start with you actually, and we'll begin with concluding remarks. If you have a couple of minutes to share with the audience any concluding thoughts at the end of this panel.
Right. Thank you. Thank you, Bhargav. And I think I can certainly share that report with the GSCC team on the climate resilient healthcare infrastructure. But I had a few comments on the previous questions, and I think if that can qualify as my closing remarks. So I think the first question in terms of the economic case, and I think where it was said that yes, for a developing country like India, there are kind of no other kind of no also push and pulls from the poverty elevation. But I was just kind of no when Dr. Maria was making that comment, a study of the World Bank kind of no of 2013, which talked about the economic case or the cost of kind of no to the of air pollution to the global economy, was somewhere, I think what they estimated was somewhere around 225 billion lost in labor income and around 5 trillion in welfare losses. And it was around at that time a combined size of the GDP of India, Canada, and Mexico combined. So I think so there is a sufficient economic kind of no case when we are talking about on working on reducing air pollution and to move towards the WHO air quality guidelines. And I think a similar study also talked about where air pollution has kind of no tapered off around 8.5% of India's GDP. So that, and this is what we are kind of no targeting when so I think so there is a sufficient, and also I think there is some kind of a positive start. And if you remember this year's budget, and similarly, I think we need to draw corollaries to WASH, what when this year the kind of strides which India has made in Swachh Bharat mission and Jal Jeevan mission. So this year's budget kind of made a start about the health determining sectors, and WASH was kind of put as one of the health determining sectors. So maybe in future, I think we need to look at air pollution also as one of the health determining sectors, and somewhere the budget when we kind of are talking about, and I think that's where what Dr. Kalpana Balakrishnan talked about in terms of subsidies and the environmental fiscal reforms or the fiscal measures which could be kind of taken up. I think that would certainly pave the way for moving forward. I think so that's on this part. But yes, in terms of as I think initially you talked about raising awareness, and so there needs to be a demand from the citizens, and I think where again there are global campaigns, and I think let me mention one of those campaigns, which is a joint campaign of WHO, UN Environment, and the World Bank, named as the Breathe Life campaign, which certainly kind of provides a platform for the cities to share best practices and demonstrate kind of progress in meeting the WHO air quality targets. And India has kind of made some strides in that. There were certain cities in late 2019, for example, Bhubaneswar, Nagpur, who have committed, the municipal commissioners out there have committed for cities to work on air pollution. So yes, we need to kind of further enhance, and even on the policy side, I think there have been various interministerial groups which have been set up, and I think one of those which I kind of can mention out here is where UN Environment and WHO country offices are kind of working very closely, and where we had set up an interministerial environment and health working group, which is led by the Ministry of Health and Family Welfare and co-led by the Ministry of Environment, Forest and Climate Change. So those are the initiatives that need to make forward. And yes, as you kind of said in the beginning, the terms of steering committee, yes, there are great recommendations. there has been a lot of work after that in form of NPCCH, the National Program on Climate Change and Human Health, which I kind of elaborated. But yes, I think we need to work more in terms of the intersectoral collaboration, and also kind of I think in terms of the best practices, and also I think sharing the positive health impacts. That's also kind of very important. For example, when the Swachh Bharat mission kind of was done, WHO did a study which kind of talked about if universal sanitation coverage is achieved, we would be able to save around 300,000 lives. So I think such positive kind of work in terms of maybe on EVs, or maybe on kind of other policy measures needs to also be brought in, which serves as a motivation for policymakers to kind of further work on it, and also kind of plug in the future initiatives. So I'll stop there, and thank you so much for this opportunity.
Thank you so much, Manjeet. Dr. Arun Sharma will take your concluding remarks now, sir. Dr. Sharma?
Yeah, I just want to add one thing, which you mentioned, and one of the participants also stated, that there is a need for collecting data from the health side and made available to in an interdisciplinary manner. That's an important thing. And here Dr. Sahani is there, so I would like to emphasize that why not the Ministry of Health and Family will take the initiative of collecting unlinked anonymous data from the patients who are visiting different hospitals and healthcare delivery centers, and use that data for providing us health-related information that will be very useful in building our own models of exposure and outcome relationship, where emphatically it can be on the basis of that said that in our own data, we can find that how much contribution air pollution is making to the total disease burden, with a special emphasis, of course, on non-communicable diseases. That's all I want to say at this moment. Thank you.
Thank you, Dr. Sharma. And I think as a health researcher myself, I feel that pain acutely on an ongoing basis. So I'll hand over your question as well as an opportunity to Dr. Sahani to make her concluding remarks as well.
Yeah, I agree with you that data from the hospitals can be collected on all the conditions, non-communicable diseases that we are having. They are increased much more because of air pollution, and we can show a direct relationship with increase of air pollution and increase of non-communicable diseases. And if we decrease air pollution, it will be beneficial, and it will decrease the occurrence of non-communicable diseases.
Thank you, ma'am. Sagnik will take concluding remarks from you now.
Yeah, thanks, Bhargav. Yeah, so just want to touch upon two quick points as my concluding remarks. One is that we need to take air pollution very seriously in India, and realize that the health burden is enormous. So any improvement in air quality is going to definitely contribute to health benefit. And the second point is that have so many different programs. We need to really interlink all these programs and basically see that as a collective way, or integrated, in an integrated manner, whether or how much actually they are improving. And for that, we need actually a proper implementation framework. We need to understand what plan is working and what plan is not working, and think that is that kind of initiative is missing from the entire NCAP implementation. All we have in NCAP is basically long wish list, really no framework to understand which is happening. Yeah. So thanks for this opportunity. I want to.
Thank you so much, Sagnik. Dr. Balakrishnan, your final thoughts, ma'am.
Yeah, well, thank you for this wonderful opportunity for discussing various aspects of the WHO Air Quality Guidelines. And one of the things we still miss is, more of such interactions at the state level and at the district level. These air quality guidelines should not be sort of viewed as some ivory towered, research recommendations. Surely ministries are looking at it in terms of standard setting. But I think there needs to be a much more concerted effort to at least sensitize a larger body of academics, on the nuances of the technical aspects of the guidelines also. They may not be implementers of standards or anything like that, but there needs to be a much broader understanding of the overall basis for these guidelines, not just within engineering institutions who normally look at air quality standards, but also within medical institutions who often contribute to the epidemiological evidence base to this. Again, referring back to the recommendations that Bhargav was part of, we had thought of sensitizing medical college students, if that is perhaps too much of an ask, but at least with help from Dr. Arun Sharma and several senior clinical colleagues, we can think of coming up with some strategy to increase the level of familiarity of guidelines amongst the medical community, and that is something that we could, as a WHO collaborating center, we could certainly contribute in any way we can, and then that will co-opt a much larger workforce for us. Next time around, we have a discussion around these issues. State pollution control boards often call upon senior clinicians locally to discuss this, and often they may not, they may have cursorily read about it in the newspaper or doing that. It would be nice to sort of educate them about the technical nuances and then the volume of work that has gone into framing these guidelines.
Thank you so much, ma'am. And I think it's an important call, and I think one that's been addressed in a very limited way through inclusion of information on environmental risk factors for cardiologists, but really unaware of any such information being distributed across other medical disciplines at all, or even in the general MBBS curriculum. So this is an area that's of importance that we need to focus on going forward. And lastly, Dr. Maria Neira, if you could give your concluding thoughts, and thank you so much for joining us.
Well, again, thanks for the opportunity. I think the most important things were already mentioned by the panelists. Again, stating that air pollution is one of the most important public health issues, and no doubt, as mentioned by the Director General of the Environment, this is an issue that in India is represented a major public health issue that needs to be solved. It will require working with different sectors, from the energy to the transport to the agriculture to the changing completely the energy policy in the country. But the results and the evidence we have for that is that the results and then the benefits for health will be enormous. We are hoping that India will lead, taking all of your creativity, your technological advance, the huge country that you are. We hope that it's true. You are facing a horrible problem at the moment, but if we put in place all the evidence, all the interventions and the tools, hopefully India will give us a surprise and then lead the transformation that is needed and reducing dramatically this terrible burden that it represents now. As a doctor, I have to say that I understand very well all of those working in hospitals in India at the moment and then feeling their level of frustration. You cannot keep treating the patients. We want to avoid the disease, and this is in our DNA as the health professionals. We need to make sure that we reduce the causes of disease and not just treating the disease itself. That's what means health. Thank you very much for the opportunity.
Thank you so much, Dr. Neira. We started our discussion today with a sort of sobering look at the impact of air pollution on health and the need for these new revised WHO air quality guidelines. We then had inputs from our panelists looking at how India can respond to these revised standards, which essentially reflect the quantity and the quality and the sort of the scale of the air pollution problem across the country. We've discussed the need for a multi-sectoral approach, taking into account all of these different sectors that are contributing to and that are affected by air pollution. We've talked about the need for more effective policy making, moving from a wish list approach that's being formulated under the NCAP towards something that reflects a more comprehensive strategy to manage our airsheds. We've talked about the need for health integration across all of these different programs, including the Ujjwala Yojana, and the initial rationale for a program like that came from the health angle. But as we move along in policy making, this health angle has really been lost, and trying to engage the health sector more deeply in this kind of policy making. And we've spoken about the need for engaging the health community and physicians far more deeply than we're doing right now. Apart from sporadic interventions from physicians talking about air quality from their anecdotal perspectives, working in large hospitals in different parts of the country, we don't really have any systematic means by which health professionals are educated on and are engaging with this issue of air quality. So there's a clear roadmap that's being laid forward by our panelists today on how do we go about achieving these really ambitious but also sobering air quality guidelines that have been set for us by the WHO. Hopefully there are several lessons that can also be learned by India as we move along on our own efforts in revising the national ambient air quality standards based on these WHO guidelines, not just from the perspective of setting new guidelines that reflect these standards, but also how do we integrate health evidence into this kind of decision making? What kind of process do we engage in to ensure that there is broad participatory action in developing these standards? How do we also ensure that there is a diversity of voices represented at the table when we're developing these new standards as well, and not just atmospheric scientists or engineers who are developing standards that are not necessarily linked to the health evidence that we have available? These are all questions that we have to answer, and perhaps these are things that we can discuss going forward. At this point, I'd like to thank all of our panelists for joining us for this important discussion, and also our attendees both in person as well as virtual in this hybrid setup that we have going on today. And thank you to the team here for organizing this webinar and for the opportunity to moderate this. Thank you so much.
Thank you so much, everyone, for joining this session today. Thank you, all the panelists.
Thank you. Bye-bye.
Thank you.
Yeah. Thank you. Bye-bye.